on terms and definitions for the description of endometriosis disease using IDEA protocol. First IDEA consensus paper was published in 2016, describing systematic approach to sonographic assessment of the endometriosis. Recently, in 2024, an addendum to the consensus opinion has been published. And in the addendum, the lateral parametrium has been included. IDEA consensus opinions describe in details systematic approach on how to examine patients with suspected endometriosis, how to describe ultrasound findings, and how to measure ultrasound findings. There are 4 steps recommended in performing ultrasound examination according to IDEA consensus opinion. The first step is routine assessment of the uterus and adnexa, searching for ultrasound signs of adenomyosis and presence or absence of endometriomas. The next step is the assessment of transvaginal sonographic soft markers, which means that we search for site-specific tenderness and ovarian mobility. And the third step is the assessment of the pouch of Douglas using a real-time ultrasound-based sliding sign. And fourth step is the assessment of deep infiltrative endometriosis nodules in the anterior and posterior compartments. When assessing ovaries with regard to endometriomas, it is recommended to document the presence or absence of endometriomas, the size, measuring in 3 orthogonal measurements, and number of endometriomas. Typical ovarian endometriomas look like as a unilocular cyst with a ground-glass echogenicity, and about half of endometriomas has this typical appearance. Sometimes endometriomas can have not typical appearance. They can be multilocular, of non-ground echogenicity, can include solid components, or sometimes calcifications. As a second step in the assessment of soft markers, we assess site tenderness and mobility of the structures in the pelvis. Here you see the assessment of the ovary that has a reduced mobility, and here again an ovary that is of a reduced mobility in the pelvis. In the third step, by assessing sliding sign, we have to focus on the fossa Douglasi. And here we see the uterus with the structures in the posterior compartment sliding against the uterus, which means that we have a positive sliding sign, when in this case we have structures attached to the posterior wall of the uterus, therefore the sliding sign is negative. And in the fourth step, a deep endometriosis lesion assessment is described. Deep endometriosis lesions look like hypoechoic lesions. They have irregular borders. They're usually solid, firm, and poorly vascularized. Deep endometriosis lesions can be located in the anterior, posterior, and lateral compartment, and the first consensus opinion is covering anterior and posterior compartment. In the posterior compartment, we can find endometriosis lesions in the bowel, in the rectum, rectosigmoideum or sigma. We can find in sacrouterine ligaments, at torus uterinus, in rectovaginal septum, and vaginal wall or fornix. Deep endometriosis histologically consists of endometrial glands and stroma in the bowel wall that reaches at least the muscularis propria level. And endometrial glands induces smooth muscle hyperplasia and leads to fibrosis. Here you can see typical appearance of bowel endometriosis with a thickened hypoechoic muscularis propria in the anterior bowel wall. Bowel endometriosis can also be described in different shapes and borders. It can have a regular outline or an irregular outline. It can be described as a comet tail sign, where deep endometriosis nodule has a progressive narrowing. It can also be described as a deep endometriosis nodule with prominent spikes to the bowel lumen, called for moose antler sign. Or deep endometriosis lesion can cover two structures and have a typical diabolo-like sign. And of course, some of the lesions may have several of features. While describing bowel segment endometriosis, it is, according to consensus paper, recommended to divide into different levels of the bowel. Lesions can be in the lower anterior rectum, drawing a border, a line along the lower part of the cervix. Then it can be in the upper anterior rectum, in the rectosigmoideum after the fundus uteri, and sigmoideum, level above the fundus of the uteri. How to measure bowel lesions? It is recommended to perform measurements in 3 orthogonal diameters, which means that we have to assess bowel lesions in 2 different directions, in sagittal and transverse direction, and perform 3 orthogonal measurements of the lesion. Sometimes there might be multicentric bowel lesion, which means that lesions may involve different bowel segments. When lesions involve the same bowel segment, when we find 2 more lesions in the same bowel segment, the lesions are called multifocal bowel lesions. And in case of multifocal bowel lesions, it is recommended to measure the total length of the bowel segment involved by multifocal lesions. Endometriosis in the posterior compartment in the sacrouterine ligament can be placed a bit laterally or further away from the attachment of the sacral ligaments to the posterior part of the uterus, or it can also be in the torus uterinus. I will show you now normal anatomy of the sacrouterine ligaments, which can be identified by placing the vaginal transducer in the posterior vaginal fornix. Here we see a video examining uterus in the sagittal view, and here we have video examining uterus in the transverse view, where sacrouterine ligaments look as a hyperechoic lines. If we have endometriosis lesions in the sacrouterine ligaments, they appear as a hypoechoic, thickening with regular or irregular margins. It can also be isolated or a part of the larger nodule, extending into vagina or attached to the bowel. And these lesions as well has to be recommended to be measured in 3 orthogonal diameters. Lesions can be also found in the rectovaginal septum. That is, topographically, by drawing a line along the lower part of the cervix, all the level below is the rectovaginal septum. And the lesions can involve only rectovaginal septum. They can also involve rectovaginal septum and also the structures close to it as vaginal wall, rectal wall, or both. Here you see how we examine the part of the rectovaginal septum at transvaginal ultrasound. Endometriosis in the posterior vaginal fornix or in the vagina look like also as a hypoechoic structure with irregular borders. Here you see a video with a lesion in the vaginal wall. In order to more precise examination, it is recommended to add some gel in the vagina, which enables the more precise assessment of the vaginal wall. Here we can see the normal vaginal wall at the vaginal gel application. And here we can see the lesion in the posterior vaginal fornix, consisting some cysts filled with ground glass echogenicity. And here is another case of vaginal endometriosis assessed using vaginal gel application, where we see there's a thickening of the vaginal wall and hypoechoic. When we assess lesions in the anterior compartment, we focus on the ureters and urinary bladder. And deep endometriosis in the urinary bladder is described as the lesion at least infiltrating the muscularis layer. According to IDEA consensus, there are three topographical locations for bowel endometriosis: the trigonum, the bladder base, and bladder dome. And the bladder also has the extra-abdominal part. Here we see a video with a lesion in the bladder wall. While assessing ureters and ureter endometriosis, it is important to be able to identify ureters. Here you see an image of a normal ureter with a typical contraction for the ureter. And in case of the endometriosis lesions, in the ureters, these lesions are usually situated further away from the ureter opening into the urinary bladder. And then the constriction and dilatation of the ureter is expected to be just above the level of the ureter. And of course, examining kidneys is another recommendation by the consensus paper in order to exclude hydronephrosis. So the first IDEA paper covered anterior and posterior compartment, and recently the addendum has been published. The addendum paper covers the lateral compartment, the parametrium, which is here you see is lined as a purple color. And in the lateral compartment, we find the sacral nerves and roots. And here are images from these publications where the normal sacral nerves are looking as a hyperechoic structures. And in case of the deep endometriosis lesions in the sacral nerves, we can find hypoechoic structures with irregular borders in the sacral plexus. So to summarize, I have shown you now 4 steps how to perform ultrasonic examination in women with suspected endometriosis. And I have also talked about how to describe the ultrasound findings and how to measure the ultrasound findings based on the IDEA consensus opinion and the recently published addendum. I recommend you to download these papers and use in your clinical practice and perform assessment in the 4 steps as recommended by these publications. Thank you very much.